want to talk a little bit about Joe Biden and his recent diagnosis of prostate cancer. And you might ask, what's this got to do with hair loss? Well, one of the things we treat patients with for hair loss is 5 alpha reductase inhibitors like finasteride and dutasteride. And so I want to discuss how this interacts with the prostate and how we should interpret the PSA. Joe Biden started doing hair transplants at least in the 1980s, and he started out with plugs, and later on his surgeon learned from people like me and Ron Shapiro, Bobby Limmer, Bill Rassman, and Brad Wolf. He learned how to properly build a hairline. So Joe Biden's hairline now looks more natural than it used to, and it's surprising that a lot of people don't recognize that he had hair transplant. So he continues to maintain hair even today, even though we know that hair transplants are not permanent. They are going to thin out over time, especially in individuals who are progressing to a Norwood 6 or 7, like Joe Biden. And here he is when he was vice president. Even then, he was thinning on the top, and even his donor area was beginning to thin. He had some retrograde alopecia, and he was already forming a Norwood 6 then. He is a Norwood 7 now. So we know that 5 alpha reductase inhibitors will slow down hair loss, and that oftentimes individuals who are experiencing androgenic alopecia will start on finasteride or dutasteride. And these products have been around since the 1980s when we began treating men with benign prostate hypertrophy. I was putting patients on finasteride back in 1990, 91, and in 1997, Propecia was, uh, became the first medication since Rogaine to be indicated for androgenic alopecia, and it came out in the brand name Propecia, 1 milligram of finasteride. Now, there are recommendations on when to perform a PSA on individuals, and these are determined by the U.S. Preventative Services Task Force, the American Urological Association, and the American Cancer Society. So, under 40 years of age, it's not recommended that you have a PSA because the risk of prostate cancer is so low. But between age 40 and 54, it's recommended that you have a PSA if you are from a higher risk category, like African American men or individuals with a first degree relative who experienced prostate cancer before age 65. Between age 55 and 69, it's it is recommended that you have a PSA annually and that you follow up the results with your doctor, and if it goes up, to have a urological evaluation. And beyond 70 years of age, it's not generally recommended. And that's because a life expectancy is less than 10 to 15 years at this point. Now, to me, this isn't really a good idea. Although I got to say, Joe Biden has been catching a lot of flack from the right media for not having a PSA and for getting prostate cancer. And, he's just following, if he didn't have a PSA, he's following the general recommendations. However, to me, if you don't do PSAs at beyond 70 years of age, it's sort of like a cop out. It's like you're not expecting to live to the general uh, expected lifespan of 81 today. And Joe is now 82. And if you live to 80, you're expected to live to 90. So I can't imagine he didn't have a PSA, but he shouldn't get a lot of flack for it because that's the general rule. Now, risk factors for prostate cancer include African American men, and you should start the PSA at age 40 to 45. Men with first degree relatives of prostate cancer before 65, and the BRCA1 and BRCA2 gene mutations. Now, there are various recommendations based on these American Cancer Society, Urological Association, but they all are pretty much similar. Unless you have a high risk, you don't really start checking until you're about age 55. Now, if you are on testosterone therapy, which I see a lot of patients in their 50s and 60s who are on testosterone therapy, before you initiate the testosterone therapy, you should have a PSA. And if it's elevated, do the workup before you start on testosterone therapy. And then if you have testosterone therapy, you should get a baseline, then again at 6 months, and then annually after that. And of course, there are other tests we look at when you're on testosterone therapy, but it is important you look at your PSA. If the PSA is greater than 3, uh, usually you get a urological workup before you start the therapy and then continue to monitor it. Now, one of the things that I like to do is look at the velocity of elevation of the PSA. So if it's greater than 0.75 per year, then you want to get a urological evaluation. Now, what about the 5-ARIs? They're going to reduce the PSA level by 50% within about 6 to 12 months of initiation of therapy. And this is not because you have a reduced risk of cancer, but it's due to a shrinkage of the prostate tissue. So if you're on dutasteride or finasteride, you should double the PSA to get an accurate interpretation. Okay? So before you start it, get a baseline, maybe even a digital rectal exam 6 months after starting and annually thereafter. Make sure you follow up with your doctor, your local doctor. When do you refer to urology? Well, when your PSA rises, when it starts to go up, if there's an upward trend, you want your doctor to send you to a urologist. If your PSA does not drop by 50% after 6 to 12 months of therapy on a 5-ARI, then you would want to get a workup. And look at the age adjusted PSA levels because it does increase with age. If your digital rectal exam is abnormal at any point, get a urological evaluation. So, what does this mean? If your PSA is 1.5, then you would, and you're on a 5-ARI, you would double it. If it was 3, you'd double it to a 6. And you probably need a urological evaluation at these points. Now, so it's important to know that you double the PSA whenever you're on a 5-ARI inhibitor. If there is not a 50% decline in the 6 to 12 months, suspect malignancy. Any rise in the PSA from the baseline is suspicious, and maintain annual PSAs and digital rectal exams for monitoring. And always look at the velocity of the increase and make sure you double the PSA level if you're on the 5-ARI. So, as you know, Joe Biden was diagnosed with a high grade prostate cancer, a Gleason 9. Don Gleason just established this score in the 1960s to evaluate adenocarcinoma, and it reflects how much of the tissue deviates from normal glandular structure. So how it works is there are two patterns, a primary pattern and a secondary pattern. And I won't bore you with the specifics, but you add these scores together to get a cumulative Gleason score. So if each one of these primary and secondary patterns have a score of 1 to 5, with 1 being normal and 5 being very abnormal, you can see that Joe Biden is at the very top of the score with a 9. And that puts him, that raises some questions. So why does Gleason score matter? Well, it determines how we're going to treat the prostate. Right? How aggressive are we going to be? And it gives us some idea of the prognosis, the risk for metastasis. Are we going to do surgery or radiation? Are we just going to survey the patient? Are we going to intervene or just watch the patient? We need to perform androgen deprivation therapy. So a Gleason score of 6 is cancer, but it has a low tendency to metastasize, whereas an 8 to 10, the PSA level you can see is going to be usually over 20, and normal would be under 4 in an individual in his 60s, and the risk to metastasis is high. So Gleason scores of 8 to 10 require more aggressive management. And grade 1 to 5, well, a lot of times these aren't reported, but they are benign prostate. So this is what a Gleason score looks like, and you look at the primary and secondary pattern, and you add the scores together. Now, this is where it gets very interesting. There were two trials. One, the prostate cancer prevention trial, the PCPT, that was done around 2002, and the reduced dutasteride cancer evaluation trial that came out in 2011. And both of these trials showed a 25% relative risk reduction in the overall incidence of prostate cancer. Now, that means that uh, you benefit mostly due to a decrease in the detection of low grade, less than Gleason score 6 tumors. And the conclusion was that they reduce the overall risk of being diagnosed with an indolent low grade prostate cancer. But there was a concern because individuals who are on dutasteride and finasteride had a slightly higher incidence of Gleason 8 to 10 tumors. Now, my suspicion in 2011 that this was due to improved detection due to shrinkage of the prostate, and indeed that's what it's turned out to be. It's a smaller prostates make biopsies more accurate. Sampling error is reduced in a smaller gland, and there are histological changes due to 5-ARIs that may mimic higher grade features. So I don't think you need to worry about a higher grade prostate cancer with these 5 alpha reductase inhibitors, but a lot of people have raised this concern to me. And in fact, there was a follow up study by Pinsky in 2013, and he showed that they have not confirmed an actual increase in prostate cancer mortality on these 5-ARIs. So it's going to reduce your risk of low grade cancer, and there's really not an association between five higher grade prostate cancers. Um, but let's get into it, sort of a professional, scientifically grounded discussion that's theoretical regarding Joe Biden. We know he had a hair transplant. We know that finasteride was indicated for treating hair loss in 1997. We know that hair loss is progressive and hair transplants thin out over time, especially in the Norwood 6 or 7, which Joe Biden is. And he has maintained graft density and donor area coverage, even though he has scars in his donor area. It's certainly probable or highly likely that he is on a 5-ARI. Now, he was diagnosed with a Gleason score 9 prostate cancer, and that raises the question of how this happened. You know, he's the president of the United States. And so we know that he has maintained hair, that he has a Norwood class 6 to 7 hair loss, which to me means he should have thinned out a lot more than this if he's not on a 5-ARI. We also know that Joe Biden has had a lot of cosmetic surgery over the years. And we know that many men who have transplants and have androgenic alopecia are on 5 alpha reductase inhibitors. And 5 alpha reductase inhibitors reduce the PSA level by about 50%, which would make it more difficult to detect cancer if you're not correcting for this by doubling the PSA level. And so, it is possible that he masked early signs of malignancy if his doctor did not double the PSA or if he didn't even do a PSA. Now, in practice, clinicians may not be familiar with this adjustment and may interpret suppressed PSAs as normal, allowing an undiagnosed prostate cancer to progress silently. And so, with his score of a 9, it begs some questions. You know, was he undergoing regular PSA screening? Was he on a 5-ARL? Did he have a false sense of security based on the fact that this was suppressing his PSA level? Or is it certainly possible that he had an inherently aggressive cancer that developed and spread quickly, even though he was doing proper screening? Now, you would think that if he was going to try to be president for 4 more years, that he would have been doing PSAs. In that, high grade cancers that are missed or when the diagnosis is delayed because you don't properly interpret the 5-ARIs, then you're more likely going to wind up with a high grade cancer. And so, for the 10th time, I'm going to say you got to double that PSA level if you're on a 5-ARI. And there is no increased risk of a high grade cancer if you're on a 5-ARI and you just or have improved detection. You have to know that there are histological artifacts caused by being on the 5-ARI, and there's no consistent evidence that 5-ARIs cause more aggressive prostate cancer. So it is certainly speculative to think that President Biden was on a 5-ARI. However, it's a plausible case for academic inquiry. And it underscores how important it is to associate yourselves with urology and dermatology to properly interpret the PSA level if your patient is on a 5-ARI. And so remember that it is very important to do the PSA in individuals in their 50s and 60s who are on a 5-ARI and to properly correct for the expected decrease in the PSA level.